In colorectal cancer, MRD testing has two implications at this point in time. One would be to treat where we would normally not treat, a positive ctDNA test, MRD test, in a situation where we would normally not deliver, for instance, adjuvant chemotherapy, like low-risk stage 2 cancers, would allow us to identify patients who are at high risk for recurrence. We do know that if we have a positive ctDNA test, it predicts recurrence with almost 100% probability. And this is a high risk factor. We also know that adjuvant chemotherapy can lower this risk, can actually halve the risk of recurrence according to recent data. So if I have a patient in a situation, stage 2 disease, based on clinical factors, I would normally not offer adjuvant chemotherapy, but this patient has a ctDNA positive MRD test, I would, of course, offer this patient chemotherapy with the idea to lower the risk of recurrence. That is the easy part, escalating treatment where we'd normally not use a treatment. Now, the more complicated question and discussion, and ethical discussion is, what if we have a patient where we would normally administer chemotherapy in an adjuvant setting like stage 3 colon cancer, routinely patients with lymph node positive disease receive adjuvant therapy, and we see the MRD test is negative, ctDNA test is negative. The problem is that we are not 100% sure that this will really lead to tumor-free state forever in patients without adjuvant therapy. So are we allowed to withhold treatment? And the question is, should we withhold treatment or de-escalate treatment? For instance, going from a combination therapy with a fluoropyrimidine plus oxaliplatin to just a fluoropyrimidine, just capecitabine, for instance. Or, which is probably another interesting factor, should we sequentially test these patients with, let's say, repeated MRD testing, repeated ctDNA tests, potentially with this personalized test, and then only administer adjuvant therapy when the test turns positive? We know that there's a lead time difference between positivity of the test and emergence of metastasis on scans of about 9 to 11 months, which is potentially the time which we could utilize adjuvant treatment to still cure patients. So it would be adjuvant therapy when you need it and not adjuvant therapy for every patient, because we know that a lot of patients really don't need adjuvant therapy. In stage 2 colorectal cancer, at this point in time, we use clinical factors, T-stage, and mainly T-stage and other factors like perforation, obstruction, lymphovascular invasion, perineural invasion, to make a decision for patients whether they should or should not receive adjuvant therapy. Now, I think it's consensus that for patients with higher risk stage like T4 and 0, we should administer chemotherapy, but we still don't have any clear data whether, for instance, oxaliplatin-based regimen is needed, and a lot of patients will probably only benefit from a fluoropyrimidine alone. Now, a molecular, let's say, residual disease test, like the Signatera test, would allow us to identify a patient population with a very high risk of recurrence in a situation like stage 2 cancer, where we definitely need to administer chemotherapy to give this patient a higher chance to be cured from their disease. This is actually not trivial. For several years, we did not know whether adjuvant therapy in this setting could actually influence patient outcomes. Because what if the positivity of an MRD test means there's a point of no return? Patients will definitively, without any question, will develop metastases in spite of adjuvant therapy. Now, we've seen recent data that's not the case. So there is a consequence of a positive test in a setting where we would normally not administer chemotherapy, because we can improve survival for patients and potentially even cure patients. We need longer follow-up, but we definitely can make a difference from the data that we've seen in some patients with MRD positive disease.
When you think of applying ctDNA to a patient population, one of the first and most obvious places is stage 2 colon cancer, because that patient starts with about an 80% chance of being cured. But we know that some stage 2s have a much higher risk. T4 disease, poorly differentiated, perforated tumors, those patients have a much higher risk than, say, only 20%. They have a much higher risk of relapse. On the other hand, there are some stage 2s that probably have a lower risk, that do better. And so we're guessing when we go into a patient like this. And so this kind of test is an obvious place to incorporate it. This kind of stage 2 disease is an obvious place to incorporate it, because if it's positive, then you know that patient still has persistent cancer in a stage 2 controversial setting, but not controversial anymore. I need to give chemotherapy. If it's negative and the patient is low risk, then frankly, I'm very comfortable not giving that patient chemo. So that's the easiest place, in my opinion, to apply this kind of ctDNA analysis. Where it will get trickier is in stage 3, because our strategy now is to treat everybody. And how certain are we going to have to be that a negative test is negative and withhold any chemotherapy from a stage 3 patient? That's the goal, right? Because we're over-treating a lot of people with chemotherapy. And so for right now, I don't think we're there yet. And some of the prospective studies that are now being done are addressing these groups of patients so that our data sets are bigger and we can answer that question.
We've seen very consistent data from various studies, whether it's a tumor-informed or uninformed test, the presence of ctDNA after surgery, after a washout period of several weeks. But if ctDNA is still there, if we find mutations that can be attributed to the resected cancer, the risk of recurrence is virtually 100%. So it's a very, very strong prognostic factor. Actually, it kind of trumps almost all the factors that we see clinically. And I believe actually we have discussion that it might need to be integrated in the AJCC staging system, that we go beyond TNM stage, for instance, to assess the prognosis of our patients, and because it clearly has treatment consequences right now. So I can easily foresee that in the very near future, almost the present right now, the ctDNA MRD assessment is going to become standard of care and will help us guide our treatment decision, at least in the area where we escalate, adjuvant therapy, and at some point potentially also de-escalate treatment in ctDNA negative cases, and potentially only use adjuvant therapy when patients over time turn positive with sequential testing.